Hello guys, welcome to the Parson series, and this is the part 5 of your chapter number 6. So last time we discussed about the refractive errors. We did see the difference between the emetropia and also the journey of the emetropization. So today we are going to start with the individual errors. The first is the myopia. Myopia, which is also the short-sightedness. So short-sightedness, where the person's sight becomes short, he is not able to see at the distant objects. So here the dioptric condition of the eye, where with the accommodation at rest, the rays are coming to a focus anterior to the retina. So you can easily remember myopia is a short word. So this is short-sightedness, and so rays are falling short to reach the retina and we are anterior to the retina. I think this is the simplest way of remembering this. Okay. So the person can thus naturally see near objects more clearly than the distance, and this is called as short-sightedness. Now, because the rays are getting focused anterior to the retina, therefore the sight becomes small and person is not able to see the distant objects, and obviously near vision will become more clearer. It can manifest with the spectrum of different clinical features and the types which we will be seeing. The majority of the cases merely result as variance in the frequency curve of axial length and curvature. Now, if you remember, last time we discussed so many causes of the refractive errors. There was an axial length, there was a curvature, refractive index, position of the lens and all. So majority of the cases of the refractive errors where you are having myopia or you are having hypermetropia, you will get some variation in either of these factors. Okay, and they did told you this very straightforward, that axial length was the most common factor. So the former being the more important, that is the axial length. Again, they are confirming that thing. Although the curvature myopia also occurs commonly as a factor of the astigmatism. So we can have the curvatural myopia also, but the axial myopia is the most common, and overall also axial length is the most important factor for the refractive errors. Such cases of simple myopia are in no sense pathological. There are no degenerative changes, although peripheral retinal degenerations can be evident, but they do not progress after adolescence when a degree of 5 to 6 diopters may be attained. So they have clearly mentioned that there is a whole lot of difference between a simple myopia and a pathological myopia. There is a limit of the biological variations. Now, though biological variations are taking place, but there is a limit, and usually it is not progressing beyond 5 to 6 diopters. We are not having any degenerative changes. It is not pathological, and you know, sometime in life you are getting a stationary illness which is usually not beyond 5 to 6 diopters of myopia. Now here they have given you the types as well as classification, clinical features also. So see, if you look at the simple myopia, so a person who is having a simple myopia is usually less than 6 diopters. Now when they are talking about the degenerative myopia, I can say it is exactly the opposite of your biological myopia or the simple myopia. It is not simple, it is not due to biological variation, it will be progressing, it will be having the degenerative changes, it will not become stationary after a certain time, because this is growing, keep on growing, because it is pathological. So here you have high degree of myopia and you also have the degenerative changes. So I think this is very easy to remember, degenerative myopia with degenerative changes. It is representing the pathological myopia. Then your third one. The third one is the pseudomyopia. Now, pseudomyopia can also be remembered as induced myopia. Actually, it is not myopia, but the patient is behaving as if there is myopia due to the excessive accommodation, due to the overstimulation of the ciliary muscle spasm. So if you remember what we study in the iridocyclitis or the acute anterior uveitis, we have inflammation, and due to that inflammation there is ciliary muscle spasm. So due to the ciliary muscle spasm, there is an induced myopia, because there is an overcontraction of that ciliary muscle which helps in looking at the near objects. So a kind of condition which is created due to this ciliary muscle spasm is simulating the myopia. That is why it is called as pseudomyopia. Then there is a thing called as nocturnal myopia. Now, what is this nocturnal myopia? Excessive accommodation due to the low contrast in dim illumination. Whenever we are looking in dim illumination, the contrast level is very, very low, and due to that also we are not able to see the distant objects. This is called as the nocturnal myopia. Now they are saying that there is something called as the induced myopia. Now induced myopia is also a type of pseudomyopia, because you know where they are saying that we have got the ciliary spasm. So this is also induced myopia, but they have given you separately nevertheless. So induced myopia, they are actually just correlating it with the blood sugar levels, like what we get in cases of diabetes, the fluctuation of the refractive error. So if you remember, we have got the fluctuation of the refractive error. There is a fluctuation of the refractive error that we get in cases of the diabetic cataract or the diabetes mellitus. This is due to the changes in the blood sugar level. That is actually called as induced myopia. Now, if you look at the degree, so you can classify this myopia into, you know, mild, moderate, severe, or you can say low, medium, high. So what are these levels? These levels are less than 3 diopters, 3 to 6, and more than 6. High myopia. So can you see, they have clearly mentioned that when I am saying that this is a case of high myopia, degenerative myopia, or a pathological myopia, then actually it is more than 6 diopters. So if I am saying that all of the following are true about high myopia except, and I say it can be 5 diopter, then that will be false, because high myopia means it should be more than 6 diopters. Okay. Now rarely we also have one myopia that is called as developmental myopia. Developmental myopia means if there is a developmental malformation and the child is actually born with abnormally long eye. Fundus may lack pigmentation, choroidal vessels are evident, while a myopic crescent is also seen. So they have not defined much here, because they have discussed this in the topic of the uveal tract, but in order to complete the list, there is also one myopia called as the developmental myopia. Now don't confuse this developmental myopia with a simple biological myopia, where there was a developmental overcorrection and there was abnormally long eye. This is not that, because here you are having the pathologies also. Pathology, like we were lacking the pigmentation in the fundus, the choroidal vessels are also evident due to the overstretching of the retina. So this is not the simple one. All right. The refraction soon after the birth may be as high as -10 diopter, but progression is usually rare. So this is, high myopia to that extent that you are getting -10 diopters of myopia. So as I said, this is not the simple myopia. The pathological axial myopia. Now we are dealing specifically with the pathological axial myopia, which is a degenerative condition where you have got high degrees of myopia. Okay, this is a progressive condition, and the refractive changes appears in the childhood, usually between the ages of 5 to 10 years, and it is increasing up to 25 years. Can you see? I told you that there is a whole lot of difference between the simple myopia and the pathological myopia. Now, simple myopia is not progressing beyond 5 to 6 diopters, while the high myopia is actually starting from the 6 diopter itself, and this condition is actually increasing from 5 to 10 years, and it is going even till 25 years. So at many times I have seen my students also, they are struggling, because every time they take the spectacles, after some time they are not able to see best with these spectacles, because again it has gone into the increase, and they want to get rid of the glasses, they want to undergo the refractive surgeries, the LASIK and all, and I always say that wait for some time, because let it be stationary. Okay, because it's very, very important that when you undergo the refractive surgery, you are at most sure that this will not increase further. All right. So this is going up to -15 or even -25 diopters. The degenerative changes in the fundus, on the other hand, do not appear until later in life, and they are becoming marked at the 5th decade. Now, side by side, when we advise them the fundus, they do not have much changes, because they are not appearing till the 5th decade. The condition is strongly hereditary. It's common in the women, It has a racial predilection, and it is common among Jews and Japanese. Most are genetic origin. Other etiological theories include the environmental conditions, like we have lack of outdoor activities, excessive accommodation, and convergence due to the prolonged excessive near work. Now, there are two important things in high myopia. See, a lot of people say that watching more of television or doing more phone work and everything has caused it. But as the studies clearly suggest that it is actually mostly genetic origin. But yes, the environmental factors do play a role. So if a person is doing more amount of near work or in the dim lights, that is kind of, causing the exacerbation and precipitation of that high myopia. Many a times myopia may be present due to the genetic causes, but because the environmental factors are favorable, the person will not develop that. So it's very, very important that one should work always in the caudal conditions. Okay, we always should take some gap while we are doing the near work. Okay, don't do much prolonged near work, and when if you are doing, then take care of the light in the room, your distance from that phone or the laptop. All these things are very, very important. Pathological curvature myopia. Now we are talking about the curvatural myopia and the pathological variety. It is typically seen in the keratoconus. So if you remember what is keratoconus, normally cornea is something like this, convex. So if there is a conical protrusion of the cornea, then that is called as the keratoconus, in which we have got the increased curvature. This increased curvature of the cornea will also lead to the pathological myopia. Then the index myopia. Index myopia accounts for myopia as a premonitory symptom of the senile cataract. So index myopia, as I told you, whenever you have got the nuclear cataract, due to the nuclear sclerosis, you have got the hardening of the nucleus. Hardening is due to the dehydration, due to the pigment deposition. This leads to the increase in the refractive index, and increase in the refractive index will change the refractive status towards the myopia. So it is due to the increased refractive index of the nucleus. It also accounts for myopia in cases of diabetes without the cataractous changes in the lens. Now every time the person is having diabetes, it's not important and it's not sure that he or she will develop cataract always. Sometimes what happens, due to the diabetes, patient may only have the refractive changes in terms of myopia. So in cases of diabetes also, patient can have myopia with or without the cataractous changes. Then we have the degenerative axial myopia. Degenerative axial myopia means we have got axial. Axial means increase in the length of the eyeball, that is affecting the posterior pole, and the part of the eye which is anterior to the equator may be normal. So what is happening in cases of degenerative axial myopia, when you are having increase in the axial length of the eyeball, you are having the changes at the posterior pole. So when I am having the changes at the posterior pole, the part of the eye which is anterior to the equator, that is absolutely normal and you are not able to see any change there. But when we have got the high degrees of myopia, what is happening? There is a over bulging or protrusion of the sclera from the posterior side. So when we have got this bulging on the posterior pole, that forms a posterior staphyloma. If you remember staphyloma, it is formed from the word staphylose. It has formed from the word staphylose, and staphylose means we have got bunch of grapes appearance. This is your bunch of grapes appearance. So when it is protruding from the posterior side, this is called as the posterior staphyloma. The edge of the bulge may actually be visible by the indirect method of ophthalmoscopy owing to the presence of crescentic shadow of 2 or 3 disc diameters to the temporal side and concentric with it, and to the change in course of the retinal vessels. Now how will you see this posterior staphyloma? They are saying that even you can find out this posterior staphyloma, the bulge of the sclera on the posterior side which is posterior to the equator, by the indirect ophthalmoscopy. So indirect method of ophthalmoscopy will show a crescentic shadow which is about 2 to 3 disc diameter. See, they have shown you a good diagram also. This is the one. So if you look here, this is your original eyeball, and when you have got the posterior staphyloma, it is going like this. So they are forming a crescentic shadow, and this crescentic shadow is 2 to 3 disc diameter. It is about 2 to 3 disc diameter. Alright. The only symptom in the low myopia may be in distant vision. Now, if I compare the clinical features, so in cases of simple myopia, the only problem that we have is that we have the distance vision not very clear, or it is getting blurred. Okay. In other cases and in high myopia, there is often discomfort after the near work due to the disproportion between the efforts of the accommodation and convergence, often leading to exophoria. But if the person is having some more symptoms also, because in cases of high myopia, what is happening, the person has to do excessive near work. Why? Because there will be a disproportion between the efforts of the accommodation and the convergence, and that will lead to the exophoria. See, when you are correcting the high myopia, we are actually giving the diverging lenses. So obviously now this patient has a problem in looking at the near objects, because the diverging rays which are coming from the near objects are even more diverged. That is why we say that in cases of high myopia, it is always good to preferably undercorrect, because there will be a disproportion between the efforts of this accommodation and convergence, and therefore the diverging lenses will lead to a tendency of exophoria. Hypermetropes have a tendency of ESO, and myopes have a tendency of exophoria. The eyes may be sensitive to the light, black spots may be seen, and sometimes flashes of light also seen. So there are more symptoms than appears in cases of high myopia. We do not have just a problem of looking at the distant objects, we also have a problem in doing the near work for a very long time. We have a tendency of exophoria, we have photopsia. Flashes of light is actually called as the photopsia. So we also have a problem of photopsia, we also have a problem of floaters, we have black spots in front of the eye, there can be a problem of glare, that is light sensitivity, all these things are there. In very high myopia, then eyes are very prominent, pupils are large, anterior chamber deeper, vision may be poor even after the optical correction, and scotomas are there. Then if I talk about the very high myopias, now if the eyeball is getting larger and larger, I will have more and more high myopia. So if I am having a very large high myopia, obviously the eyeballs are very large. So eyeballs becomes, you know, very prominent, and sometimes these kind of a patient will also present with the pseudoproptosis. They are also presenting with the pseudoproptosis. It appears as if they have proptosis, but actually they do not have proptosis. The pupil size are also very large, anterior chambers are deeper, and they may be associated with open angle glaucoma. Even they have the scotomas, and these scotomas can be central as well as peripheral. Now talking about the ophthalmoscopic appearances. So we have got ophthalmoscopic appearances in cases of high myopia. A very typical thing is the myopic crescent along with the changes in the central fundus. So myopic crescent means you have got a crescentic shadow. Okay, so if you look at the fundus, and you have this optic disc here, and the larger area will be your macular area. So what is there, towards the macula you have a crescent shaped degeneration. This crescent shaped degeneration is actually called as the myopic crescent, and because it is towards the macula, sometimes it is also called as the temporal crescent. Therefore it is also called as the temporal crescent. So there are a lot of changes that you see here. Then you also have what you call as the chorioretinal myopic degeneration, because you know in high myopia there is so much of thinning of retina, there is overstretching, that behind chorioretinal vessels appears very prominently, and that is why that fundus is called as the tigroid fundus or the tessellated fundus. Degenerative changes are also occurring at the periphery, and peripheral retinal degenerations therefore are very, very important, and you should exclude them. You should always advise these patients to undergo indirect ophthalmoscopy, because usually what is happening, these degenerations can lead to the retinal detachment, retinal holes can also be there. Then we can also have the degenerative changes in the vitreous. And you know, whenever you have got degenerative changes in the vitreous, vitreous being a gel-like structure, they are forming the clumps, and therefore they are seen as floaters. Now these floaters are seen more plainly by myope than by other eyes, because the entoptic image is larger. So if I talk about the floaters, the myopes are seeing these floaters more plainly, but in comparison to the other eyes, because other eyes may have the entoptic phenomena. These degenerative changes may have serious visual consequences, and they are among the more common causes of severe visual disability. So if the person has developed the degenerative changes, I will say that they are under the serious category of the refractive changes, because these are those refractive changes which are taking the person outside the visual disability. They are leading to the blindness. So now the person is not under only the vision loss, the diminution of vision, that is your ocular morbidity. They are going to the visual handicap. So it is that one thing which can bring the patient to a different level, is this degenerative changes. So these are the changes in the fundus that they are trying to show in cases of myopia. Can you see, we have got the breaks also, we have got hemorrhages also, we have got crescentic shadows, because you know there are a lot of fundus changes that you get in cases of myopia. We get hemorrhages like the Foster Fuchs spots. Foster Fuchs spots are there. These Foster Fuchs spots are actually the hemorrhages. Then you also get the breaks. Can you see these breaks here? So they are also showing you breaks. These are your lacquer cracks. Foster Fuchs spots are there. We have got the lacquer cracks. We also have the crescentic degeneration. These are your myopic crescent. Myopic crescent is also there. We have got chorioretinal degeneration. The vessels are very, very prominent from behind. So all these changes do occur in cases of myopia. All right. Now, if I talk about the prognosis, then low to moderate degree of simple myopia, okay, they have a good prognosis. So all those children who are having just simple myopia, not a very high degree, it is just, you know, 5 to 6 diopters. This has a good prognosis until and unless they are saying that it is occurring in a very, very small children, because in such a small children we do not expect to cooperate and wearing the spectacles all the time. So in that it may cause a problem, but otherwise it has a good visual prognosis. They are not likely to progress also. Another thing is that when you are having this simple myopia of 5 to 6 diopters in children, and until unless they are very, very small, usually we do not have the risk of there being progression. The same condition in a child before the age of 6 or 7 years give rise to anxiety if it is not of congenital type, since at this stage the degenerative condition is clinically indistinguishable from the simple. So one important thing is that whenever you are having myopia in a child less than 6 to 7 years, that is an alarming button. Now why? Most of the time these children should be hypermetropic, because at the time of birth they are hypermetropic and their undercorrection may lead to hypermetropia. But if they are having myopia, that means there is some problem there. Second important thing is that at this stage usually you are not able to distinguish whether it is a simple myopia or it's a degenerative myopia, whether or not we will have the degenerative changes, the progression, the degree of myopia, the floaters, the vitreous degeneration. So there are so many things. The former is of grave prognosis. The former is of grave prognosis, means if it is a degenerative condition, then usually the prognosis is grave. Almost it is certain that it will progress to very, very high degrees of myopia, and more often than not, all those people who develop the myopia less than 6 to 7 years, usually they are developing the degenerative myopia, and it is going to a very high level, 10 to 15 diopters, accompanied by serious degenerative changes in the fundus and the defect of vision. So I can say that if you are having a question something, then always consider myopia to be degenerative if it is detected less than 6 to 7 years, because it is always better to overdiagnose than to underdiagnose. So always consider the case of myopia less than 6 years of age as degenerative until proved otherwise. Now we look at the treatment. Attention must be paid by the use of suitable correcting spectacles or the other optical aids like contact lenses. So you have to correct it. So for this you can use the spectacles also, you can use the contact lenses also. In low to moderate myopia up to 6 diopters, the full distance correction for the constant use is prescribed, and patient must be warned not to hold near the work closer than the ordinary reading distance. So the first dictum is for those people who are having low to moderate myopia, means up to 6 diopters. So we can give the distance correction, we can give them proper instructions not to hold the near work very, very close, because if you are bringing it very, very close, as you bring closer and closer, more and more diverging rays, and then it will become impossible for that person to converge the diverging rays coming from the near objects. If any discomfort is experienced, then obviously we can give the weaker lenses for the near work, because obviously most of the time the patient's distance vision is actually corrected, but they feel problem in the near vision. That is the main barrier in the full correction of myopia, especially if much reading or a close work is done. Children should wear their distant correction constantly, not merely in the interest of their eyes but also in the interest of their mental development. Now this is a very, very important thing, and I think I will have to exaggerate this, that this has to be explained to every parent, that mostly they say that when they are my child works or say watches television or doing phone, only then he or she can wear. No, the spectacles has to be worn every time. Why? Because that is also affecting the mental development. Now if the child is not able to see the distance things, the stimulus is not there, and when stimulus is not there, that will not be acting as a stimulus for the development of binocular single vision. So I will say that this is not only the physical vision, it is also the mental development. So whole of the mental development, the personality, the IQ of the child actually depends upon how constantly he or she is wearing the spectacles. The children with low degrees of the uncorrected myopia cannot be expected to take normal interest in their surroundings, since they cannot see the distant objects as clearly as the fellows. So I told you this, that for their mental development also it is of utmost importance that the patient wears the spectacles. Then coming to the high myopia. Now if I talk about the high myopia, then we are not giving the full correction here. It is wise to slightly undercorrect even for the distance, and the same or weaker lenses may be ordered for the near work. Now here you do not have the choice, you have to give the different near correction, because for the high degrees of myopia, very high concave or the minus lenses are given, so that will definitely create a problem for the near vision. You have to give a separate one, and even for the distance also you can go for slight undercorrection. In the highest grades, patient often see best with the lenses which are decidedly weaker than the full correction. They should be allowed to choose those they prefer. So when they have got highest degrees of myopia, it is a fact that obviously they will be most comfortable with those lenses which are weaker than the full correction. And usually what we do, we give them the trial frame and we offer them some variety of lenses, and we do ask them whichever they are comfortable with. Like, we cannot be hard and fast in this, so it depends upon the individual's convenience. We have to give them a choice and they can choose from them. One reason that the strong minus lenses considerably diminish the size of the retinal images and make them very, very bright and clear. Now the retinal images are diminished because lenses have to be worn further from the eye than the anterior focal plane. So now what is happening when the person is wearing these high concave lenses which have been given for the myopia? So what is happening, the size of the retinal images are very small. That's why these are called as the minus lenses. But apart from that, the images becomes bright also, they are becoming clear also. But yes, they are becoming smaller in the size because lenses have to be worn farther from the eye than the anterior focal plane. That is why in cases of the myopic correction, the size of the images goes on decreasing and decreasing. Spectacles for high myopia. Therefore, the spectacles for high myopia should be worn to fit as closely to the eyes as possible. Again, a very important thing. So, if they ask you that where they should actually fit these spectacles, so when they are wearing the spectacles for the myopia, it should be worn as tightly to the eye as possible, because from before also they are actually wearing them, okay, further from the anterior focal plane. So if the spectacles are going further down, you will have even more diminution of the image size. So you have to wear it now very close to the eye. Okay. Moreover, much artificial astigmatism and the distortion of the image is produced by looking obliquely through the strong lenses. Then second important thing is that when they are wearing these spectacles, you know, from a distance, now when they are looking obliquely through these lenses, artificial astigmatism is also developing. This artificial astigmatism can be actually avoided by the use of the contact lenses. So for that, contact lenses are very useful, and that is why, if you remember, I told you a question was also there that the contact lenses are of high therapeutic value in cases of high myopia. If the spectacles are not constantly worn in very high myopia, the requisite amount of convergence for the near work may be impossible. So it's very important that the person should wear the spectacles every time, otherwise the convergence that is required for the near work will not be available. The effort to converge is thus abundant, so that the reading and other near work become uniocular and disused eye will become divergent. So what is happening when you are not using the spectacles and you are doing the near work, the eye is not able to converge, so that eye will not be used, and always you will have the disuse atrophy. So this eye which is not used will go into the amblyopia, and this eye becomes the lazy eye, and the lazy eye has a tendency to be divergent. So this will go into exo or the divergent squint. That is why the eyes having myopia have a tendency to go towards the divergent squint. Now coming to the prognosis. So the prognosis of the this degenerative eye myopia can be grave. So that is always, you know, alarming sign. Degenerative myopia cannot be taken as simple myopia. For economic reasons, high myopes with degenerative changes in the fundus or positive family history should avoid an occupation in which close work is necessary. If you remember, I do tell you this in cases of retinitis pigmentosa also. Whenever a person has a degenerative pathologies, he or she always should be very careful, because of course you cannot change the plane of that disease. It is progressive, then it is severe, there is not much that you can do. But one thing is that you can guide that person and you can counsel that person to choose the right profession. At least he or she should not choose that kind of a profession which is totally guided with the vision. So there should be there. They should also be counseled about the warning signs of the retinal breaks or the retinal detachment. Then second thing, because you know, every time they are having the degenerative myopia, there is often a risk involved that there can be degenerations, there can be retinal holes, there can be retinal detachment. So you should tell them, they should have this in mind, that they can have all these problems and what can be the alarming signs and symptoms, so that whenever they feel something like this, earliest they can seek for the medical help. Now, after the spectacles, talking about the contact lenses may be worn instead of the spectacles. They have the advantage of wider field and the larger image. So, as it is often said, contact lenses are better in comparison to the spectacles, especially in cases of myopia, as far as the field is concerned, as far as the image size is concerned. And then the third, of course, is the surgical treatment of the myopia. For the patients who do not wish to use the spectacles or they are intolerant to the contact lenses, we can do the refractive surgery. I think this is a very vague thing, who do not wish to wear spectacles, because I have not seen any person in my life who wants to wear the spectacles, even the boys. What to say of girls? So this was about the different treatment aspects of the myopia in detail, talking about the myopia, the severity and the prognosis of myopia, how we can treat it, and what are the pros and cons, how to wear the spectacles, what are the things that you should keep in mind while treating a case of myopia, and what are the things that you should counsel to the patient while you are treating with the myopia. So in the next session, we will be dealing with the refractive surgeries also that is being done to correct the myopia. This is all for this session. Do like the video and do subscribe to the channel to get the latest updates of all the videos which are posted. Thank you and happy ophthalmology.